Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, and welcome to our Triage podcast. My name is Beth Johnston. I am a partner in our healthcare and FDA practice at K&L Gates. With me today are two of my colleagues, Carolyn Merritt and Leah Richardson, who are experts in the application of the federal physician self-referral law, otherwise known as the Stark Law. In this episode of Triage, we will discuss the subset of the COVID-19 blanket waivers published by CMS on March 30th, which pertain to the Stark Law. On a separate but somewhat related note, we will also briefly discuss CMS's recently announced expansion of its accelerated and advanced payment program, specifically as to the question of whether providers who have made submissions under the Stark Self-Disclosure Protocol are still eligible to participate. First, let me acknowledge that we are living in extraordinary times. If you are a healthcare provider or someone who regularly works with healthcare providers, we very much appreciate your service. We will get through this COVID-19 crisis only because of the incredible expertise and dedication of those on the front line. We hope that this podcast can benefit in some small way with the issues that you are having to deal with, at least as it comes to Stark. So with that, Leah and Carolyn, thanks for joining.
Happy to be here, Mary Beth.
Thanks, Mary Beth.
Let's start off, and in a nutshell, explain what a blanket waiver is and under what authority are they granted.
Sure. So Section 1135 of the Social Security Act authorizes the Secretary of the Department of Health and Human Services to waive or modify certain Medicare, Medicaid, CHIP, and HIPAA requirements. There are two prerequisites that must be met before the Secretary can invoke this waiver authority. First, the President must have declared an emergency or disaster under either the Stafford Act or the National Emergencies Act. Second, the Secretary must have declared a public health emergency under Section 319 of the Public Health Service Act. As of March 13th of this year, both of those prerequisites were met. So under 1135 of the Act, the Secretary may grant waivers to ensure in any emergency area and during any emergency period that sufficient healthcare items and services are available to meet the needs of individuals in the emergency area and enrolled in Medicare, Medicaid, and CHIP, and healthcare providers that furnish those items and services in good faith, but are unable to comply with one or more requirements described under Section 1135B, may be reimbursed for such items and services and exempted from sanctions for such noncompliance, including sanctions under the Stark Law, absent any determination of fraud or abuse.
So with a blanket waiver, what does a provider have to do in order to rely on the waiver?
So a Section 1135 blanket waiver is self-effectuating, and so there's no additional action that a provider needs to take advantage of the waiver.
What is the effective date of the Stark waivers?
The effective date of these Stark waivers is March 1st of 2020.
So if a hospital, for instance, had already entered into a non-compliant arrangement after March 1 as a result of the COVID-19 crisis, is it now covered?
Yes, that's the result of the retroactivity of these blanket waivers is that the blanket waivers are effective as of March 1. But note that not every requirement under Stark is subject to these blanket waivers. And so we still have to analyze whether any arrangement would be covered under the blanket waiver.
Okay, thanks. So Carolyn, the introduction to the blanket waiver announcement on March 30th for all the waivers states that they are in effect through the end of the emergency declaration. The waiver language itself in the Stark blanket waiver says that they will terminate as set forth in 1135E of the Social Security Act. So what does that actually mean? When do the waivers terminate, and what should providers be mindful of?
So the Stark-specific waiver language on duration seems to be more precise when it references the expiration of the waiver. It specifically references Section 1135E of the Social Security Act, under which waivers are in effect until the end of the emergency period or 60 days after the waiver was first published. The waiver period can be extended by the Secretary for periods of up to 60 days until the end of the emergency period. In any event, the language in the blanket waiver announcement seems to be a clear signal that the Stark waivers will likely be extended until the end of the emergency period, but providers may want to tie the effective period of any waived arrangement to the 60-day period and then renew them at that time.
So as I read the CMS Stark waivers, the only arrangements that can benefit from their flexibility are arrangements that meet a COVID-19 purpose. Leah, how is that term defined?
So a COVID-19 purpose is a defined term under the blanket waivers, and that term means one or several of the following: diagnosis or medically necessary treatment of COVID-19 for any patient or individual, whether that patient is diagnosed with a confirmed case of COVID-19, securing the services of physicians or other practitioners to furnish medically necessary patient care services, including services not related to the diagnosis and treatment of COVID-19, but in response to the COVID-19 outbreak, ensuring the ability of healthcare providers to address patient and community needs during the outbreak, expanding the capacity of healthcare providers to address patient and community needs during the outbreak, shifting the diagnosis and care of patients to appropriate alternative settings during the outbreak, and addressing medical practice or business interruption due to the outbreak in order to maintain the availability of medical care and related services.
So if a physician has been complaining to its hospital since the expiration of his recruitment agreement, for instance, in November, that the financial package was insufficient for his move to the community, can the hospital rectify that situation by using the COVID-19 waiver?
No, because that would not be a COVID-19 purpose under the blanket waiver.
The blanket waivers mention in a couple of places that they apply to remuneration and referrals solely related to COVID-19. I'm reading that to mean that any non-compliant arrangement must be prompted by COVID-19, but that if a physician makes a referral of a non-COVID-19 patient to a hospital, that referral in particular is still not outside the scope of the waiver. Do you agree?
Yes, that interpretation would be consistent with the definition of COVID-19 purpose that I just described, which includes services not related to the diagnosis and treatment of COVID-19, but in response to COVID-19 outbreak.
Okay. Carolyn, let's move on to the substance of the waivers. Describe what they cover and how they operate.
Sure. So CMS grants 18 blanket waivers that address a wide variety of arrangements. They're actually pretty specific, and I would encourage our listeners to go through them to fully understand the particular arrangements that will be allowed during this emergency period. In the interest of time, I won't go through all of them, but generally these can be broken down into different subsets of financial relationships between the DHS entities and physicians. The first subset of waivers are those dealing with personal services arrangements or items and services which would typically be accepted under Stark's fair market value exception. As we all know, generally, personal services arrangements between DHS entities and physicians need to be provided at fair market value. Under the blanket waivers, the Secretary allows for the payment of remuneration that is below and above fair market value. Additionally, under this subset, the waiver also covers compensation arrangements that do not satisfy the writing or signature requirement of an applicable exception. The next category of waivers address the leasing of property and equipment. Whereas Stark generally requires these leasing arrangements to be consistent with fair market value, the waivers allow for leasing arrangements to be provided at rates below fair market value. The same waiver I just mentioned regarding the writing and signature requirement would also be applicable in the leasing context. Additionally, the Secretary addresses remuneration in the form of medical staff benefits and non-monetary compensation and waives the regulatory caps on both of these types of compensation arrangements. One other subset of blanket waivers address low-interest loans between DHS entities and physicians. And finally, in addition to physician compensation arrangements with DHS entities, the waivers also address physician ownership in hospitals and home health agencies, as well as the waiver of certain of the group practice requirements under Stark.
So we don't have time to walk through each waiver, so let's talk about some specific examples. CMS has included in the blanket waiver its own examples, so we'll use some of those, but also some that have actually been posed to us. For the first example, let's say a hospital wants to keep as many people as appropriately possible outside of its emergency department. It would like to offer at no cost telehealth capabilities to community physicians for use with their own non-hospital patients. Is this covered by a waiver?
Yes, this situation should be covered by waiver number 9, which addresses remuneration from an entity to a physician in the form of non-monetary compensation that exceeds the limit set forth in the non-monetary compensation exception. So you should be good there.
So, Leah, a hospital needs additional physician coverage, but given the circumstances, is unable to find willing physicians at pre-COVID-19 fair market value rates. May it pay above fair market value?
Yes. Waiver number 1 specifically permits remuneration from an entity to a physician that is above fair market value for personally performed services to the entity, so it should also be good there.
Another example might be a hospital owns a medical office building that leases to physicians who are now financially strapped because of the drastic decrease in business due to COVID-19. May it reduce or even waive rent payments?
Yes, because the COVID-related purposes include business disruption, waiver number 5 would permit rental charges paid by a physician to an entity that are below fair market value for the physician's lease of office space. We don't see anything that would restrict the waiving of rental payments for a short period, but it may be a good idea for legal counsel to review such requests for complete waivers of rental payments.
So here's an interesting example that's been posed. Many of the local daycare centers are closing due to COVID-19. Independent physician practices are therefore finding it difficult to stay open and cannot provide testing or patient care services. May the local hospital directly provide daycare services in its own daycare at no cost? Or otherwise, could it cover the cost for daycare services at a third-party daycare for both physicians and their staff?
Yes. As with the provision of the telehealth services, the direct provision of daycare services by a hospital could qualify under waiver number 8, which was related to remuneration from a hospital to a physician in the form of medical staff incidental benefits that exceeds the cap if the child care is provided on site. If the child care is provided off site, waiver number 9 would apply, which Carolyn just mentioned, related to non-monetary comp. In that situation, we would want the hospital to pay the daycare directly so that you're not providing cash to a physician, which would take you outside of that exception. And so although it's not specifically addressed, we don't think it would be unreasonable for the hospital to reimburse child care costs if it doesn't have its own child care facility.
Helpful, thanks. So Carolyn, let's say a hospital has numerous employed physicians whose compensation is productivity-based. Due to COVID-19, their productivity is nowhere near typical historical levels. May the hospital hold them harmless?
Yes, we have actually had clients ask this question, and in our experience, it's likely that the employment arrangements could be amended in such a way that could actually remain STAR compliant. But in the event that there were fair market value concerns, waiver number 1 would allow for remuneration to be paid to a physician that is above fair market value for the personal services of that physician. I would also want to just mention that to the extent that the employment agreement contained a directed referral provision, we would recommend that counsel take a look and analyze the potential impact of that directed referral language in light of the waiver requirements.
So finally, I found waiver 18, number 18, interesting. It waives compliance with the writing and signature requirements of an applicable exception, but it says that all other elements of the exception must be met unless it's been otherwise waived, like fair market value. So it doesn't explicitly waive the requirement that compensation not change more frequently than once in a 12-month period. So let's say that a hospital has an existing personal services contract with a physician at a fair market rate, and it increased that compensation for COVID-19 purposes if this means changing the compensation more than once in a 12-month period.
Yeah, so that's a really interesting question. While this situation isn't explicitly addressed in the waiver language, certain examples in that publication contemplate paying above a previously contracted rate. So it appears that CMS would find this approach acceptable.
Can the compensation then be returned and changed again to its pre-COVID-19 rate after the crisis is abated?
Yeah, we would argue that not only would be fine, but it actually would be required if the interim payments were above fair market value and you continue to pay them outside of the public health emergency period. That might be problematic. So we would think that that would be required to go back to fair market value once the emergency is over.
Okay, very helpful. As I mentioned, CMS also included other examples in the blanket waivers. Were there particular ones that you found instructive that we haven't covered?
I found it really helpful that the Secretary recognized business disruption to be a COVID-related purpose. We've had clients ask specifically about providing loans to physician groups who have been adversely affected by the pandemic. And waiver number 10 clearly contemplates that an entity can provide a low-interest loan to a physician, which will likely prove extremely helpful to healthcare providers.
Yeah, I would add that under waiver number 7, the Secretary is allowing for donations of equipment and supplies by physicians to hospitals, and this will be incredibly important from a public health perspective during the crisis.
Carolyn, I noticed that CMS states that any remuneration described in the blanket waivers must be directly between the entity and the physician or stand in the shoes entity. Does this mean the waivers are not available to indirect compensation arrangements?
Yeah, so it's unclear whether the waivers of indirect arrangements were intended to be excluded from the blanket waivers. It could be that since the volume and value requirements were not waived, indirect arrangements may not need waivers, or it could be that in any event, the waivers are likely broad enough to permit the necessary relief. Legal counsel will likely just need to look at these types of arrangements on a case-by-case basis to consider ways to properly structure them.
So Leah, does CMS require in the blanket waivers that the parties utilizing the waivers maintain documentation? And if so, what are you instructing clients with respect to this?
Yeah, the blanket waiver does note that the parties must make records relating to the use of the waivers available to the Secretary. And so that indicates that, documentation is going to be required. Our advice has been to document the relationship just as you would a START compliant relationship, and then note where the reliance on the waiver was needed.
So turning in closing here to a slightly different topic, but one that we've been asked that's START related. Carolyn, we've been asked whether designated health service entities like hospitals that have filed START self-disclosures under the CMS protocol still qualify for participation in the accelerated and advanced payment program. It is beyond the scope of this podcast to describe all aspects of this program, but briefly, what is an accelerated advanced payment?
Right. So in order to increase cash flow to providers and suppliers impacted by the COVID pandemic, CMS expanded its accelerated and advanced payment program to a larger group of providers and suppliers. An accelerated and advanced payment is intended to provide funds when there's disruption in claim processing or submission. These payments can also be offered during national emergencies to accelerate the cash flow to affected providers and suppliers. CMS can provide these accelerated or advanced payments during a public health emergency to any Medicare provider or supplier who submits a request to its MAC and meets the required qualifications.
So under the program, who is eligible?
Right. To be eligible, the provider or supplier must, 1, have billed Medicare for claims within 180 days prior to the date of request. The provider or supplier must also not be in bankruptcy. The provider or supplier must not be under active medical review or program integrity investigation, and the provider or supplier must not have any outstanding delinquent Medicare overpayments.
With respect to the third element, does an SRDP qualify as an active medical review or program integrity?
No, it appears that CMS is referring to medical reviews conducted by the Center for Program Integrity, or MACs, as well as program integrity investigations performed by the ZPICs, for example. So we think it is reasonable to assume that hospitals who have filed START self-disclosure should still be eligible.
Thank you. So thanks so much, Leah and Carolyn, for joining this podcast. If any of our listeners have questions or comments, feel free to let us know. Also, for other COVID-19 related information, please visit our COVID-19 Resource Center on our website and subscribe.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.